Idiopathic transverse myelitis. Pathophysiology is like immune mediated destruction of the spinal cord. In here, there is immune mediated destruction of the spinal cord, often post infectious, like molecular mimicry. If you think about the clinical feature, there is bilateral motor weakness, classically flaccid, like lower motor neuron progressive to late spastic. There is bilateral sensory dysfunction. So, bilateral motor weakness, bilateral sensory dysfunction, and there is distinct sensory level, and there is autonomic dysfunction, like bowel or bladder is involved. In TM, it's a bad, like bilateral motor weakness, bilateral sensory loss, autonomic dysfunction, and distinct sensory level. If you think about the diagnosis, there is MRI of the spine, no compressive lesion present in here. There is T2 hyperintensity. If you do lumbar puncture, there is increased WBC, increased immunoglobulin G index. If you want to treat a patient with TM, high dose IV glucocorticoid and plasmapheresis. If you want to differentiate between transverse myelitis and Guillain-Barré syndrome, first of all, motor symptom. In transverse myelitis, there is early flaccid and late spastic. But and if quadriplegia, then weakness is in the lower limb. Then weakness is both in the lower and upper limb is equal, and the GBS in the motor, like ascending paralysis and weakness more in the lower limb than in the upper limb earlier in the disease. If you want to see the sensory, there is clearly identifiable sensory loss. But in Guillain-Barré, there is mild sensory loss, no spinal cord level, motor, sensory, and then autonomic. There is bowel, bladder for TM, and Guillain-Barré for cardiovascular instability. If you look at the cranial nerve, in transverse myelitis, none of the cranial nerve is involved, but in Guillain-Barré, there is oculomotor, there is glossopharyngeal or facial paralysis. There may be bilateral facial palsy. If you do EMG or NCS, mostly normal, but in Guillain-Barré, there is peripheral motor and or sensory nerve conduction is reduced. If you do MRI, there is focal enhanced area of T2 signal for transverse myelitis, and Guillain-Barré usually normal. CSF fluid pleocytosis and increased immunoglobulin G index, and Guillain-Barré there is elevated protein, absence of pleocytosis. Absence of pleocytosis.